Hello, everyone, and welcome back to Echo Asthma Bootcamp. I'm your facilitator, Ashley. I'm joined today by my coordinator, Rachel, and our wonderful hub team, Dr. Meredith McCormack and Dr. Louis Karitsky. Now let's get started with our fourth lecture in the series, Biologic Treatment Options, hosted by Dr. Kerr.
So welcome everybody to today's Echo Asthma program, session 4 on biologic treatment options for severe asthma. My name is Dr. Sucharita Kerr. I'm an assistant professor at Tufts University School of Medicine and an adult pulmonologist at Tufts Medical Center. And I look forward to spending the next hour with you talking about some of the exciting biologic treatment options we've had in severe asthma. So starting with the GINA guidelines, we've reviewed these before. GINA guidelines do not necessarily specify which exact drug to use, but really provide us with guideline to help selection of a treatment for a particular individual patient. And that really depends on the patient's own disease characteristics, their preferences, what phenotype of asthma they may have, what their functional ability is to perhaps use a medication, and then to overall consider the complexity of the medical regimen. The biologics in asthma are among the step 5, the rightmost on the GINA guideline. So there are 5 approved biologics currently in the United States. Omalizumab, which is an anti-IgE monoclonal antibody, is the oldest. We've had about 18 years of experience with this drug. Mepolizumab was then approved many years later and is an anti-IL-5 monoclonal antibody. Restless, which is an IV formulation, again an anti-IL-5 treatment option. Benralizumab is an anti-IL-5 but really works against the receptor rather than the IL-5 molecule itself. And then the most recent kid on the block is Depilomab, which works against the anti-alpha subunit of interleukin-4 receptor. The most important thing about these drugs is that while they do significantly improve exacerbations, or decrease exacerbations, improve lung function, and reduce the amount of oral corticosteroids that a patient is exposed to, it's really important to remember that these are add-on treatments. That means that it is only used for patients who have uncontrolled asthma, despite the regular use of a combination of medium to high dose inhaled glucocorticoid and a long-acting bronchodilator, and people who have impaired lung function. So it's really for those patients who cannot be maintained despite step 4 GINA guidelines. A little bit more about these approved biologics. All except for Restless are subcutaneous by route. Restless is the only one that's IV. Some of these, Omalizumab and Mepolizumab particularly, are also approved for ages over 6. So for a pediatric population, this table highlights what the patient selection is, and we'll talk a little bit more about each of these drugs in detail and what the evidence is behind using these drugs. And then I really want to use this table to highlight some of the adverse effects. So for Omalizumab, which is an anti-IgE treatment, anaphylaxis is about 0.2% of patients. While the risk is really low, it is recommended that the patient carry and know how to use an epinephrine injection with them at all times. The risk of this anaphylaxis is highest initially when they initially get the drug, but certainly has been reported up to 7 days out. Patients also complain sometimes of local reaction at the injection site. For Mepolizumab, in some of the studies, patients have had zoster. It's rare, again, less than 1%. And the guidelines typically say to consider a vaccine against zoster if medically appropriate. It's important to note that some of these vaccines are live, and so if the patient is at risk for disseminated zoster, for example, if they're on high-dose steroids or on immunosuppression, it may not necessarily be feasible to give them a shingles vaccine. Headaches are quite common, but can be dealt with some Tylenol, and local reaction can be a possibility as well. For Restless, interestingly, one of the side effects is oropharyngeal pain. Anaphylaxis has also been described. Again, it's 0.3%, so it's a low risk. However, is a real risk and is associated with a boxed warning for the drug. For Benralizumab, this is indicated predominantly, again, for eosinophilic asthma, and some of the side effects include headache, pharyngitis, and a hypersensitivity reaction. And for Depilomab, finally, Injection site reactions are common in about 15%. Hypersensitivity can be noted, and this can present as urticaria, other rashes, evidence of serum sickness. Paradoxically, these patients can also have eosinophilia, and it has been attributed in about 4% of patients who receive Depilomab, as well as the presence of some vasculitis. Ocular symptoms should be looked for when patient is on Depilomab, as these patients can often develop conjunctivitis or keratitis. And I'd like to highlight that for all of these drugs, because it's meant to be an anti-eosinophilic inflammatory drug, it's really important to take a detailed helminth infection exposure history, particularly about travel or if they've ever had a helminth infection in the past. And it's important to treat that helminth infection before starting any of these drugs. So let's go through each of these drugs individually. So omalizumab was approved back in 2003. So as you know, we have many years of data and really good data to support this drug. It has been used for patients who have moderate to severe asthma with a positive skin allergy test, and those who've been poorly controlled otherwise on an inhaled corticosteroid. The dosing for the drug really depends on what the patient's weight is, as well as what the IgE level is and the age. Typically, though, depending on these levels, a dose comes to somewhere between every 2 to 4 weeks. It's a subcutaneous injection. And the data really supports the use of the drug. Cochrane analysis a few years ago of 25 studies showed that it significantly reduced the exacerbation. And overall, there was an absolute reduction in exacerbation compared to placebo, where it was 26%, down to omalizumab, where it was 16% exacerbations. It also has shown to reduce the risk of hospitalization, the significant absolute reduction in the risk, as well as a decrease in the risk in the utilization of inhaled corticosteroids, but not necessarily oral corticosteroids. Overall, in this Cochrane analysis, it was shown that omalizumab was associated with less adverse reaction compared to placebo, except for the local injection site reactions, which were higher, about 9% in omalizumab compared to 5% in placebo. Again, there is a risk of anaphylaxis. People have to carry the epinephrine injection with them, and it's up to us as healthcare providers and nurses to educate the patient about the use of it and the need to carry it with them, particularly around the time that they're getting the injection. The next is mepolizumab. This was approved by the FDA in 2015 as an add-on therapy for severe asthma in kids 6 and over with an eosinophilic phenotype. Of note, an autoinjector is available for this drug. However, it's approved for ages 12 and above. It's a standard dose of 100 milligrams administered subcutaneously every 4 weeks. And there are really 3 pivotal studies that led to the approval by the FDA. First is the DREAM study that enrolled over 600 patients with severe asthma and tested 3 different doses, 75, 250, and 750 milligrams. And this study really showed that mepolizumab cut down exacerbations by 50% at all doses with an excellent safety profile. The MENSA study following the DREAM study recruited 576 severe asthma patients, gave them both IV as well as a subcutaneous dose and compared that to placebo. And both IV and subcutaneous cut down the exacerbations by 50%. Not only this, it also showed improved lung function as measured by FEV1 and improved ACQ scores or symptoms of asthma. And then finally, a study of 135 patients published in the New England Journal of Medicine that recruited patients with severe asthma showed that mepolizumab cut down oral corticosteroid dose by 50%, 32% decrease in exacerbations, as well as a better ACQ score. The next is Restless. This is an anti-IL-5 drug approved by the FDA in 2016. It's an add-on therapy for patients with severe asthma, mainly for adults 18 and over with an eosinophil phenotype. Because it's an IV drug, it takes a little bit longer to administer, and it's given by an infusion every 4 weeks with a dose of 3 milligrams per kg over 20 to 50 minutes. There is a 0.3% risk of anaphylaxis with this drug. And there are 3, again, pivotal studies that I'd like to highlight here. The first one is 2 randomized controlled trials that recruited about 953 patients with severe asthma or with eosinophils over 400. This study showed that Restless cut down exacerbations by over 50%, and they had similar worsening of asthma symptoms in both Restless and the placebo group. a randomized controlled trial that recruited 325 severe asthma patients compared to different doses. And this study showed that the lung function is measured by FEV1 as well as symptom questionnaires is measured by ACQ, and the AQLQ did better in the drug or the Restlizumab group compared to the placebo group. And that the higher dose, the 3 milligram per kilogram dose, did better than the lower dose. And finally, a third randomized controlled trial in chest back in 2016 recruited about 490 patients with a 4:1 randomized design, used the dose 3 milligrams per kg. And it's interesting to note that the positive effects, the benefits of Restlizumab in this population was seen only for people who had an eosinophil count over 400. And hence, that's when we consider using this drug, is when people have eosinophil counts over 400. Particularly important to note that in this study, that folks who had EOS below 400 did not benefit as much. The fourth drug is benralizumab. This is an anti-IL-5 receptor antagonist approved more recently in 2017 for ages 12 and above with severe asthma with eosinophilic phenotype. The dose, again, is a standard dose, 30 milligrams subcutaneously. The important thing here to note is that for the first 3 doses, it's administered every 4 weeks, and then thereafter, there's flexibility to administer it every 8 weeks. There is also an option for self-injection here with a pre-filled auto-injector that was more recently approved in 2019. And again, the pivotal studies that showed, the first one was a randomized trial that showed that benralizumab cut down annual exacerbations rates significantly in these patients. This study looked at every 4-week administration as well as every 8-week administration, and both did better compared to the placebo. In addition, lung function was better as measured by FEV1 as well as the symptom score. Long-term data from the above study and aggregate data of over 1,100 patients showed that 75% of these patients had a decrease in more than 50% dose of oral corticosteroids after about 84 weeks of treatment, and 39% of patients identified a more than 90% decrease in the steroid use. So it really helps cutting down steroid use and exacerbations in these patients, in addition to improving lung function and symptoms. And the most recent drug is Depilomab. It was approved in 2018 for ages 12 and above for patients with severe asthma. It's an anti-IL-4 receptor alpha monoclonal antibody that further blocks the downward signaling both of interleukin-4 and interleukin-13. It's approved for 2 different doses. We also have some long-term data for this because it has previously been approved for another indication for atopic dermatitis, and more recently for asthma. Both doses are self-administered, they're subcutaneous administered. The first dose is 400 milligrams for the first dose, followed by 200 milligrams every 2 weeks. And then if the patient has oral corticosteroid dependent asthma, then it's recommended that a higher dose be used. This is 600 milligrams for the first dose and then 300 milligrams every 2 weeks thereafter. Home administration is possible. And there are pivotal studies that show that it cuts down exacerbations by 47% in patients who were treated every 2 weeks, associated with improved lung function. And another study of 200 patients showed that it cut down the dose of oral corticosteroids by 70% in the drug group or the Depilomab group compared to only about 42% in the placebo group. And 80% of Depilomab patients had at least a 50% steroid dose reduction and a 59% lower exacerbation in the Depilomab group. So really tremendous amount of data with all of these drugs. Now, while there are 5 approved drugs by the FDA for patients with severe asthma, I'd like to mention at least one, Teslapillaimab, which is currently in development, and these are the results of the phase 2 trial that came out a couple of years ago in the New England Journal of Medicine. Teslapillaimab is an antibody that is directed against the thymic stromal lymphopoietin, or TsLP, which, if you remember, is pretty upstream on that graph that we discussed last time in the inflammatory pathway. And this study is called the Pathways trial. It's a phase 2 randomized, double-blind, placebo-controlled trial of Teslapillaimab in patients with a poorly controlled, moderate to severe asthma, despite medium to high doses of inhaled steroids. And they recruited over 580 patients that were randomized to either placebo, which are the gray bars, or the colored bars, which are different doses of Teslapillaimab. And what you could see is that there was significant reduction in the annualized rate of asthma exacerbation in the 3 doses compared to placebo. Most of these p-values are just statistically significant with the exception of a couple. I think the most important take home from this, although it's a phase 2 study, the importance here is that the drug decreased severe asthma exacerbations independent of their type 2 status. So one thing to highlight is all the 5 drugs that we have so far that are FDA approved have been approved for type 2 asthma. We do not have any FDA approved drug for non-type 2 asthma. So this is really exciting that this drug has potential for helping our patients who have non-type 2 asthma, who really don't have much with the exception of our standard inhalers at this current time. And it's one of the reasons that the drug was fast-tracked by the FDA in 2019, and more to come about this in the future. I'd like to also briefly mention the role of bronchial thermoplastic. This is rarely done, but I think it's important for us to talk about it. It involves 3 bronchoscopic sessions that leads to radiofrequency ablation or heat wave application to the airway smooth muscle. As you know, the smooth muscle in asthma plays a very important role in bronchoconstriction. And so this applies radiofrequency ablation to the smooth muscle in the airway. The effects have been studied in the short term, unfortunately, because of the bronchoscopy and the airway irritation, it actually leads to increase in asthma exacerbations. There was also a large placebo effect noted in these clinical studies. Long term, however, it has been shown to reduce exacerbations as well as improve symptoms in the following year. There's no clear evidence, however, to guide patient selection as to who's going to benefit, who's not going to benefit. And so the current utilization is really restricted to clinical trials or registry uses. So I'd be really amiss if I didn't talk about COVID-19 and what to do with these biologics in our current pandemic climate. There is a paper that was recently published where a group of experts across the world really got together to discuss what to do with patients who are already on biologics in the pandemic or if they get COVID-19 infection. And so these are some of the highlights from that paper. Again, I have to preface this by saying there's not a lot of data to support it, but these seems to be reasonable conclusions. First, in the absence of data that would indicate any potential harm, continuing the administration of biologics during a pandemic in patients in whom such treatment is clearly indicated and has been effective. Second, in prior studies, no risk of increased infection susceptibility or immune suppression effect has been reported to date. In fact, omalizumab had a possible anti-infectious effect, and hence they recommend no need to discontinue the drugs during a pandemic. And until more information is available, patients with severe asthma plus comorbidities infected with the SARS-CoV-2, decision for maintaining or postponing biologics until patient recovers should really be done on a case-by-case basis, supported by a multidisciplinary team. Our experience here in my institution is that we've continued people on biologics and they've done well. Some patients, we've actually transitioned them to home administration to avoid having them come in to the institution for shots, particularly for the need of physical and social distancing and avoiding exposures. Particularly for omalizumab, there has been some provision that has been provided for the pandemic to allow a self-administration at home with certain guidelines in place that we can discuss at a later session. So I'd like to finish up by talking about some of the guidelines for referral to an asthma specialist. These, in my mind, include patients who've had a life-threatening asthma exacerbation, such as those who've been in the intensive care unit, potentially intubated for their asthma, patients who, despite appropriate treatment, have not met their goals, patients with atypical presentations who we question the diagnosis of asthma, patients with particular comorbidities such as ABPA or allergic bronchopulmonary aspergillosis or eosinophilic granulomatosis with polyangiitis, patients who you are potentially considering biologic treatment, patients who require consistently step 4 or higher treatment according to the GINA guidelines, patients who require 2 or more corticosteroids in 1 year, as well as folks who require hospitalizations for exacerbations. Thank you for listening and for your attention, and we'll open this up for Q&A.
All right, thank you everyone. Thank you, Dr. Kerr. I know that's a very long one, lots of information in that session. So we'll open up the floor to Dr. McCormack. What are your key takeaways from this lecture?
There are exciting new options, some less new in the case of omalizumab for patients with our severe poorly controlled asthma. And the majority of these are targeting IL-5, the newest Depilomab IL-4, but these are all for T2, patients with T2 inflammatory profiles. We'll talk a little bit more about that. And several of the new ones are available for home injection. I think that's an important practical piece of information. And then also highly relevant right now is that for patients that are needing this level of treatment, there's no indication that we should be altering that therapy in the context of the COVID-19 pandemic.
Dr. Kuritsky, do you have anything to add?
Not much, really. One of the things that's surprising me to be looking at for this class is the relatively small number of patients who have been exposed in registration trials. Cardiovascular disease and diabetes are the two things that fill the offices of primary care clinicians most commonly now. When we look at a trial like for atrial fibrillation, for the new category of agents called the DOACs, direct anticoagulants, the trials are literally 10 to 20 times greater in size than these populations. So when we look at a trial for Dabigatran or Rivaroxaban, there are 15,000 participants. And I think this gives us a much more clear window of what's really going on in two directions. I think we don't want to overestimate adverse effects because it's such a small number of people that just a few people one way or the other might magnify the adverse effect profile. So I am surprised by that. And I'm presented with a dilemma now, which is it's difficult to choose which medicine the patient should start with. And I'm glad I don't have to make that choice, that someone who's an expert can help make that choice for us. So I think it's very exciting to be on the beginning steps of a new direction in management of severe asthma.
Thank you.
Dr. McCormack, I have a question for you. I know on a previous session, Dr. Kerr mentioned that for her patients that were self-administering at home, it was actually much more expensive. The insurance company charged them differently. So have you heard anything about that?
That's a great point and something we should all maybe be more mindful of, keeping an eye out for. I have not had that feedback, and I have had many of my patients that are on home therapy started in office-based therapy, and I haven't heard that it's been more expensive. Now, I don't know if, for example, the landscape might be different for people that were transitioning, and so it's a great point to look for, but I haven't had that feedback, but maybe it's because we're not asking the right questions.
Thank you, Andrea. Do we have any questions from the group about this lecture or the key takeaways or any experiences with bringing your patients on with biologics?
I have a question for the group. How come nobody has asked what the heck is thymic stromal lymphopoietin? I can't even say it or spell it. I didn't know thymuses had lymphopoietin. How did that thing get into the mix? I mean, we do get wake-up calls like this from time to time. 20 years ago, someone described that calcitonin G-related protein was related to migraine, and now that word is in our conversation. But I never heard of that entity being involved in any other part of medicine. Anybody know anything about that entity, TsLP? I don't know anything to comment on. I notice there's a lot of quiet going on right now.
You know, I did have a long presentation. I met with an AstraZeneca rep, and she had this long PowerPoint, and a lot of it went whoosh. But I know that they did have a poster, well, virtually at the American Academy of Allergy, Asthma, and Immunology, or was it Quad AI? I think it was Quad AI that just had their annual conference, and they did have a poster on that. So if that's something we can track down, I'm happy to share that with the group.
We'll send it to Dr. K in particular. Dr. McCormack, do you have anything? I don't know if the group has anything to say. Do you have any comments about it?
Well, just one thing I would comment is just that it's high up in the pathway, so it's more proximal, which, and so I think to that end, it's sort of biologically consistent that it would work on T1 and T2 pathways. And I think I mentioned this is anecdotal, but I have had patients that were in a trial that we were a site with who were on the drug and had a very remarkable response. Like as some of my many of my patients that have met the criteria for the biologics we'll talk about that are currently available have had a remarkable response. So I'm very excited to sort of to have more tools for those, because I think of my patients with severe poorly controlled asthma, the ones that don't have eosinophilic phenotype or endotype are ones that I really am very limited in my options for. And so we really need more therapies. And this is just hopefully one of many in the future.
Thank you, Dr. McCormack.
You know, maybe I've mentioned it before with this group. I can't quite remember, old age moment. But I had a son that started back in 2007. I can't remember when it was. Anyway, he started on Zola, which was the only one on the market at the time. And previous to that, he'd been in the hospital 7 times, and 2 of those were ICU. And we would time out his medications. He had allergy shots. We had removed all the carpet from our home. We had done everything. And for our family and for my son, that literally saved his life. He would start to get sick, and previously I would just pack my bag for the hospital, because with a simple cold, I knew where we were headed. I knew it'd be pneumonia and another hospitalization. And for some of those patients, that tiny little percentage that have the severe uncontrolled asthma, it literally can be life-saving. And there can be a lot that families have to deal with. We would have to get, we had to get the pre-authorization. We would have to get copay assistance every year. There was a lot to go through that. But my son was on it for 7 years until he started college, and he did really well. So for what it's worth, if you have any patients that are considering it, it really, I feel like, saved his life.
Thanks so much, Andrea. Yeah, and after next week we'll have our shared decision-making conversation, which is a great session. And then after that, we talk about managing injectable medication. So we get a little further into the prior auth concept and just other things that you might need to potentially bring that into your practice. So. All right, do we have any other questions from the group?
I had one other thing I wanted to put out onto our group airway, and that is I'm wondering if anybody is looking at whether or not our biologics have an enduring effect. And what I mean by that is in the desensitization trials for persons who have allergies with or without asthma, what we find is that once a person has had sustained desensitization and they build up blocking IgG antibodies to the antigens that offend them, they have a durable, at least as far as we know, for as long as 4 years or more. In some of them, it appears to be indefinite, that once your IgE factories are put to sleep for a while, they say, well, maybe I don't need to bother to make IgE. Maybe this thing really isn't an offender, and I can take a break for a while. And what I'm wondering is, I don't know the literature yet, and whether we should be watching for the opportunity for any of these other biologics, and particularly omalizumab. Is there going to be a time period where we can say, all right, we've taken the step to block this sensitivity, and it's going to now be more durable? One other factor about that I think it's important for people to know, I sometimes hear parents who are reluctant to take the step that they think is unpleasant about desensitization if their child needs subcutaneous. And what has been demonstrated is that if you take a child that has a strong allergic diathesis and desensitize him, for instance, to house dust, and he's asthmatic very young, the likelihood of him developing future allergies to other antigens is also reduced. So there's a bigger payoff than just one antigen that your patient might be looking at. So I think asthma is a pretty costly issue. And then one other thing I wanted to put out, because I made a mistake about this once a long time ago, and that is, don't rely upon how asthma patients tell you they feel before you send them home or out of the emergency room. I saw a very frightening study, and I had a patient, a young woman who went to the emergency room in a local hospital, and she said, I feel fine. And she went home. She died from asthma, because it's been shown that you heard our speaker earlier mention what's called near fatal asthma. There was a study done on people who had, quote, near fatal asthma, which means they were admitted and had to be intubated. Otherwise, they would have died. When they studied those patients further down the road, they found that when they hooked them up with ventilatory resistance and volitionally lowered their PO2 and raised their CO2, these individuals were less sensitive to hypoxemia and less sensitive to hypercapnia. And whereas you or I might have been breathless and frightened, these people were looking you in the face and saying, yeah, I feel better, I'll go home. So we have to rely on objective measures. It's never just good enough to rely on an opinion from a patient, because it can cost a very serious consequence unless we make formal physical metrics before we let people go home from acute care settings.
Do you know, I'm glad you brought that up. I have a friend that's a longtime respiratory therapist, and she said, really, those with asthma, we're notorious compensators. It starts to become normal for us, and so we just compensate for it. And she said she's seen people with really low readings on their oximeter, and I'm fine. You know, I've been worse. So yeah, you're right. I'm so glad you brought that up. And I think another thing people don't realize is that we have 10 deaths in America every day from asthma. Still, with all the medications, all the clinics, with everything that we have, we're still losing 10 people a day. And that's one of the reasons. So glad you brought that up.
Thank you both for sharing that. Okay, well, very exciting. We have a patient case presentation from Dr. McCormack today. I believe you have sharing rights, so feel free to open that up for us.
Awesome. And yeah, I'm very glad you brought that up as well. This is a patient who I was pretty worried about. And I think that, at least for me, is very true, that many of my patients that are, as they become more towards the severe and poorly controlled end of the spectrum, maybe have their reporting becomes less specific for that very severe, those upticks. So this is a patient that I saw. I started seeing her, she's 31 now. At the time that she developed asthma, she was in elementary school. And she didn't know exactly the age, but probably sort of in the middle of elementary school, maybe around the age of 8 or 9. And she, prior to, for at least a decade, prior to the time that she came to see me initially, she had been very well controlled on no medications, but for occasional albuterol, which she used very rarely. And she was a fairly avid exerciser, ran. She has a son who is 2. During her pregnancy, didn't have any change, didn't have any exacerbation of her asthma. And then she got a COVID-like illness in February, March of about a year ago. And after that was hospitalized twice for symptoms that were respiratory symptoms that were characteristic of a flu-like pneumonia, and then really with features of asthma exacerbation on top. When I saw her, she was over a month or 2 out from that time, but was still having a much more asthma symptoms. And this was just a rapid shift in her asthma control towards poorly controlled. She had cough that was throughout the day. She described shortness of breath, maybe a little, I put at rest here because it was just with very minimal activity. And again, this is someone who's otherwise quite healthy and had good, was very, her conditioning had been good, and she was exercising frequently up to this point. She also had shortness of breath with the exertion. She had chest tightness when she had symptoms. And this was happening, I should have had daily here. This was really daily, and she had nighttime symptoms as well. She had a history of allergies. She had allergic asthma. She had had allergy testing in the past. And she also knew that she was allergic to milk and had a pretty significant milk allergy that during this time seemed to have gotten worse. She was in contact with milk, particularly in caring for her son, and had to completely offload that activity to her husband and family members because she would have a reaction. In general, she didn't really have seasonal component before because she was so well controlled. And she did report improvement with albuterol use. And she was discharged from the hospital both times on steroids and had been unable to really taper her steroids down with the taper off that had been planned. And she had tried to taper. When I saw her, she was trying to go from 40 to 20 to lower than 20 and was getting stuck around the 20 level. She described all kinds of triggers, any kinds of odor. Her asthma was so severe that she couldn't be anywhere near the kitchen because strong odors would trigger her asthma. Going outside would trigger her asthma. Any kind of real fragrance or cleaning product. So she was spending a lot of time in a bedroom. She was on an inhaled corticosteroid at high doses and montelukast, and had been started on Spiriva and was still using her albuterol, MDI, and a nebulizer. She would have missed work. She was working a lot from home, but really was fatigued and feeling poorly and wasn't able to function quite as well. She certainly had less physical activity. And as I mentioned, she had been hospitalized and then re-hospitalized for these symptoms. She was better than when she was hospitalized, but I was still quite concerned about how fragile, tenuous she was, and and whether she was safe in her home environment. She was a never smoker. This patient was a trainee in one of the, she was a physician who was doing her training as part of her residency. And she was in a research year, so she was able to work from home and not be as involved in the hospital setting. She didn't really have any other significant other medical conditions except for her history of allergies. And her labs, when I saw her white blood cell count was normal and she didn't have any elevated peripheral eosinophils, but she was on steroids and had been on steroids for well over a month. I did look back about a year prior, she had a CBC, and at that time, when she was well controlled, her eosinophil count was 180. She had a history, Aspergillus antibody was checked, and that was negative. Her IgE was 35. She had pulmonary function tests, which showed mild airflow obstruction with an FEV1 of 78% predicted and a bronchodilator response of 15% improvement in her FEV1. And she had a normal CT scan that was done after her hospitalization. When I examined her, her exam was significant for wheezing, and throughout all lung fields, it was her loudest in expiration. And her pulse oximetry, I don't have her vital signs, but her pulse oximetry was normal. And so one of the questions I thought would be a good one to ask of the group is, does this patient have severe, difficult to control asthma? And since we were talking about biologics today, I thought it would be good to entertain the question of, do we think she deserves a biologic or trial of a biologic at this point? And this was a question I was thinking about with her clinically as well.
All right, so it's open to the group. What do you think?
Did I miss this? Did you go over what her refill rates were?
I did not. That's a great question. I felt very, I did not review her refill records specifically, but so she had just started these medications. Before that, she really hadn't been on much, and she'd been on these medications for several months and reported very good adherence. And she was super detail oriented, like talking about times and her schedule and how she would approach things. So I actually probably could verify, but and I think we all should verify, because I think adherence is one of those things that sometimes you can get fooled, or not fooled, but people could be hesitant to uncover that they're not really being adherent. But for her, I felt pretty confident that she was really adhering to the schedule. I also saw her on a televisit as well, which was kind of helpful because I could see her in this environment and sort of see her approach literally laid out.
And was her inhaler technique correct as well?
That's a great question. And we did go over her technique, and she did have good technique. And actually on here, she was using HFA rather than dry powder inhaler, which I should have corrected on this, but she was not using a dry powder. And if she had, then I probably would have switched just to make sure that that wasn't a factor, or potentially could have considered switching.
We have a hand up from Maureen. You go ahead and unmute yourself if you can.
Hi, any chance that she may have developed GERD from all the oral steroids that she was on, or had some sinusitis that got going during her COVID-like illness, and all that is flaring up her lower airways?
Those are great questions, particularly because she did have a very prominent cough feature, and those could certainly be driving any aspect, but particularly with the cough. She did not have any upper airway symptoms. And really, I saw her often and in televisits as well as in person, and she consistently didn't have that. I think GERD could be more of a potential, and she was started on a PPI, but it didn't make a difference in her symptoms.
And Tan asks in the chat, can we see a quick reminder of her symptoms from the first page, or if you want to just
Sure.
read them out?
She had cough throughout the day, and shortness of breath with minimal activity, and as well as and was very limited in her ability to do any activity, as well as sort of chest tightness, discomfort when her symptoms were more active. And one of the more striking features was that her triggers were she had so many triggers just that all of us would be encountering in routine life. Like she could not go into her kitchen if anyone had cooked recently at all.
Yeah, Tan says that sounds severely limiting for her. It certainly does.
I will say I was really, so she had been in the hospital twice. And so we talked quite a bit the first time I saw her was in telemedicine, whether she was safe at home, because she was really not leaving this room. And I think we could have made a case to send her directly, like by ambulance, to the emergency department at that point. She was someone that was very, her progress over time was very slow. So it was challenging because her improvement was so slow that we ended up coming up with this very tight system of management with the idea that she would just call 911 on a moment's notice if things were to change. And I think she understood very well that she was at that level, and that any subtle change was really meant that she needed to call 911. Not ideal. I can tell you some of the things we did for her. And I thought I would present this case a little bit. She's the most striking patient I've had in what I think is a post-viral exacerbation of her asthma that was very long duration. I've had other patients that have had something similar, but much, much milder than this. And I thought maybe she would be a good person to present and then kind of talk about maybe the rest of the spectrum. She, because we were having trouble getting her off steroids, I ended up prescribing her budesonide, a nebulized inhaled corticosteroids that she added on to her twice daily high dose ICS-LABA combination to try to give her more steroid, to see if we could, adding that would allow us to bump down her prednisone. and that was one of the things we did. I would have also done a nasal route if she had any nasal symptoms. And I actually think we did that anyway at the very beginning, just to see whatever impact we could make. And we set up the system. She had a peak flow meter as well, and that we weren't really using that as a primary driver, but we couldn't get her in for pulmonary function test. So we early on, so we used that just as a little bit of a tool. And then we had this plan that she would really, we talked a lot about what would make her go to the hospital, what would make her call 911, just to Andrea's point, just to make sure that we had a plan for when she would seek more care. She ultimately got better over time, but it just took a long time, and we slowly walked down that prednisone. I did think about a biologic in her because we had added, she was at max therapy, she was poorly controlled, and at this time had severe asthma because it persisted for months, but really with this inciting factor of a viral illness. Ultimately, we decided together to kind of wait and see. And because she was slowly improving, we didn't end up doing that. She never went on a biologic, although I think you could have certainly made the case. We could have tried it, but I think sort of in joint decision making, we ultimately decided not to, and to watch and wait, with the idea that that would be another thing we could try. And ultimately, she improved over time, but it took a long time. Go ahead.
We talked about this a little bit last time. Do you think there's any rationale as a primary care clinician, or for some of my colleagues online who don't think of themselves as asthma specialists, for trying to choose a different member of the same class? Like, do you think, like she was on salmeterol, we see the nod from Gina about using formoterol combination instead. Would vilanterol be better? Would indicaterol be better? Or once a patient is stable and they're as tense as this person is, do you really need to stick with what they got instead of taking chances at going around to a new medicine? Because in all the other spheres of medicine where we've looked at this, we've gotten surprises. Even in like pain medicine, we found that rotation of opioids. People start responding, and then so they started looking at subreceptors. Does that make a difference? Do you ever switch around the basic ingredients? Do you say, I'm going to try a different LABA, I'm going to try a different steroid, even though I don't have any reason to believe it would be better, it's worth a try? Could you advise us about that?
I do think it's worth a try. And I also think that the idea of thinking about, because now we do have nebulized long-acting beta agonists, nebulized inhaled corticosteroids, and nebulized short-acting beta agonists and short-acting antimuscarinics. For people like this, where they're, she's really tight, sometimes she might not be getting a full inspiration, that those nebulized therapies might enhance your delivery. And then switching classes, I think, as well, particularly if with regard, and Andrea brought this up, to technique, observing technique, and then asking maybe about the formulation as well as the medication.
I had one other comment to make. This relies upon a study that's almost 20 years old. I think it's remarkable the detail you knew about this patient's life. I felt like you were really a master of attending to every detail in her life, and that's a beautiful thing to see, that our patients are just not a number that comes in, here's your disease, here's the fix, but you really knew who this young woman was. Despite that, there was a study I saw that talked about a different type of ventilation in asthma. It was actually a controlled trial where they brought asthmatics in and had them write about stressful experiences in their life. And subsequent to writing about the stresses in their life, their asthma control got better. And it was as if just unburdening themselves and looking at the stresses they had in their life and feeling like they had the opportunity to share that with something made their asthma better. I'm probably as guilty as anyone else in today's busy world that my listening ear is not as open or enduring as it could be. Do you feel like this woman's issues in her life were sufficiently attended to, that we really had a good handle, where she had an opportunity, if that was a channel of her life that needed improvement, that we offered her enough space to gain the potential power of that?
That is such a great point. I think, potentially the stress and trauma of this initial insult could have been enough to, to cause ongoing stress. My sense with her was that she had an incredibly supportive environment, which was quite surprising actually all along. From her ability to get support, like she was living with her parents. I think not being able to fully care as you would want for your 2-year-old, it was certainly a stress. But I will comment just on a couple other patients that I've had who I think that the role of stress is enormous. And the way we are able to address that is in many ways limited, because we can't change everything we would want to. But I have 2 quick examples. One is a patient who is now in his mid-30s who had horrible asthma. And he said now he has perfect control and is on minimal meds. And that was after he came out and sort of openly let the world know about that he was gay. And he said that just that process changed the dynamic and changed the stress. And so he identifies that as a point where stress changed. And I have another patient who just came in who went from calling me all the time for chest pain and shortness of breath. And I saw her Wednesday and asked her what changed. And she said, I don't have stress anymore. She had taken some measures. And, it would be great if we could wave a wand and take the stress away and see what that does. But I think often that's playing a large role, and it's hard to know how that fits in. It's a great point.
Thank you, everyone, for all of your comments. Thank you, Dr. McCormack, for sharing your case. We're coming up to the 3 o'clock hour. So is there any final words you want to say about this patient before we go into our housekeeping?
I'll just quickly say that we are rolling back she's off prednisone, she's off the nebulized budesonide, and our most recent visit, we were talking about what to do because she's trying to plan another pregnancy and thinking about timing and achieving a period of stability and so forth. So she's definitely in a much better place, but the road was a little longer than you would like. So.
Thank you, Dr. McCormack. All righty, well, it's that time. We have our post-test polling questions. And now for our knowledge questions. Which of the following drugs is an IL-4 receptor alpha antagonist? Is it benralizumab, mepolizumab, omalizumab, Depilomab, or Restless? And question 2, which of the following is not targeted by the currently approved biologic agents? IL-5, IL-17, IgE, or IL-4? Some interesting mixed results. Dr. McCormack, what are our answers?
All right, so the first one, which of these is an IL-4 receptor alpha antagonist? And that's Depilumab, which blocks IL-4 and IL-13. And for the second one, which of the following is not a target? That is IL-17. And the others, IL-5, IL-4, and IgE, are all targets of the currently available biologic therapies. Nice job.
Very nice. Thank you, everyone. We're just a couple more seconds left. I have to ask, does anyone have a patient case that they would like to discuss next week? Will be, thank you, perfect. You can't volunteer, no. We would love to hear.
Someone else, yeah.
Oh yeah.
Bring your cases.
Someone else. We're talking about shared decision-making next week. It does not have to be in line with shared decision-making, but if you have anything that you'd like to discuss, any patients you'd like to discuss, please raise your hand now if you would. Ahlam, are you going to present next week? We got an okay. Excellent. Oh, thank you so much. Oh, I'm thrilled. Okay, well, we will reach out to you via email to make sure that you have the the case presentation form, and then we'll chat with you next week about your case. Thank you all so much for joining us today. Echo clap for Ahlam. Thank you. And hope you have a wonderful week. We'll see you next time to talk about shared decision making. Thanks, everybody. Bye-bye.